So there's a lot going on in the world of peripheral artery disease, much as you heard from HFpEF, from Dr. Design, and diabetes, and many of these overlap. So I'm going to talk a little bit about the latest iteration of the guidelines and some of the data behind them. And I do want to acknowledge that Dr. Bott here was one of the authors of the guidelines. These are my disclosures. A couple of points. These aren't new points, but they're emphasized, is the growing prevalence of peripheral artery disease. This isn't just a phenomenon of more diagnosis, but it's an aging population with more cardiometabolic disease. And so it's estimated that over 12 million Americans have peripheral artery disease, and this rate is going to continue to grow. The guidelines do differ from the U.S. Preventive Services Task Force on the notion of screening, the ACC and AHA. And as you can see from these data from Alan Hirsch, when you look at people who are above 70 years of age or 50 to 69 with a history of diabetes or smoking, 1 in 3 have PAD. And so as you think about your clinical practice, there's a lot of disease out there that's not being detected. Now, why does it matter? Well, one of the notions is cardiovascular risk, that identifying it identifies patients at very high risk. They may not be symptomatic for coronary disease. And you can see here in data from the Fourier trial that those patients with peripheral artery disease were actually at much higher risk of MACE than patients who had had a prior MI or a stroke. But that's not all the same, and I think one key take-home from the guidelines is heterogeneity of risk. I learned the term polyvascular disease from Dr. Bott from the REACH registry and other data sets. And on the right side of the slide, you can see that when you stratify, those in yellow with PAD are still higher risk than those with an MI or prior stroke, even if they've never had an MI or stroke. But it's the patients that have both, what Alan Hirsch used to call metastatic atherosclerosis, that are the highest risk patients. So knowing whether someone has PAD is helpful for risk stratification for MACE. And it's not just MACE. Actually, we looked in one of the large atherosclerotic data sets with a TIMI study group at incident heart failure in patients with atherosclerosis. And actually, patients with peripheral artery disease are at a much higher risk of incident heart failure than patients with prior MI or prior stroke, obviously driven by shared comorbidities. It's also important to note that PAD is actually the most frequent first manifestation of cardiovascular disease in patients with diabetes. And so as Dr. McGuire was talking about all these exciting new drugs, do any of them modify PAD outcomes? And it's something that we'll talk about. So traditionally, the guidelines have been focused on MACE reduction, noting that people with PAD have atherosclerosis. And more recently, we've evolved to really think about limb outcomes. Now, any of you that do peripheral procedures or see these patients know that their morbidity is driven by limb symptoms, functional decline, amputation, acute limb ischemia. But often in medical therapy trials, we don't look at these outcomes. And that's been a major evolution, I think, both in the research space and in the guidelines. But traditionally, we've sort of looked at things like amputation, which is something we do to people. It's not actually a biological outcome, and thinking that a one-size-fits-all is going to approach. And for many years, we had no effective therapies, not recognizing that actually there's a lot of heterogeneity in what drives amputation. So these are data from the DECLARE trial. You saw data from Dr. McGuire about dapagliflozin. Here we looked at amputation because of a signal from the CANVAS trials. And I think the take home is that if you have diabetes and PAD, you have very high rates of amputation, but also limb infections, ulcers, and so on. And that the dominant driver of amputation in PAD and diabetes, or diabetes alone, is infection, not ischemia. So you can't just fix conduit arteries and think that you're going to prevent amputation. And that has brought around a novel notion. This is not just the ACC/AHA guidelines, but also the SVS Wi-Fi concept of assessing wounds based on the wound, the ischemia, but also the degree of foot infection to adequately heal. You can't just improve blood flow, but you have to treat the entire spectrum of disease. And then one of Dr. McGuire's collaborators at UT Southwestern, Josh Beckman, who's a close friend, he published this great data set here showing that microvascular disease is an independent driver or predictor of amputation. And when you put together the two, which is the same as sort of these patients with diabetes, microvascular disease, and PAD, you have very high risk of amputation. And so there's more to the biology than just the traditional sort of atherosclerotic risk factors. So as we sort of think about treatment, what are the goals of treatment in PAD? And traditionally, it's always been the far left, to reduce the risk of heart attack or stroke, which is, of course, important. There's always been this notion that if you have PAD, you have CAD, and you're likely to die of ischemic heart disease. That's sort of true, although there's a lot going on in that population. But what we've recognized in the more recent guidelines and others is that it's major limb outcomes and functional limitation that really are the dominant morbidities in these patients, and that leads to some differentiation in the guidelines around how we think about therapies. All right, so these aren't new data, but they're sort of foundational to the guidelines, which is lifestyle modification, healthy diet. On the left, exercise really does work, supervised exercise. And my colleague who passed away a few years ago, Will Hyatt, drove a lot of the data for exercise therapy. It's as effective as stenting, and together they're very effective for symptoms. So exercise therapy and then smoking cessation. These are, you can't randomize people to smoking, of course, but observational data that people who continue to smoke after surgery do really poorly. The problem with supervised exercise, and just to be sort of transparent about it, is that we talk about it and it works, but nobody's doing it, even though Medicare covers it. And so this is an analysis by Sanjay Devakaran at the Brigham, who looked at about 130,000 people. This is after Medicare coverage for supervised exercise therapy, and about 99% of people aren't doing it. And so this then has opened discussion in the guidelines and other places around home-based exercise, and what does it mean, and how can you do effective therapy or exercise therapy? The reality is that if you don't do exercise to the point where you develop pain, it doesn't actually improve your walking function. Now, quality of life is different. People who exercise but don't feel pain, they don't walk better, but they think they're getting better. And it's actually different for people that are walking better because they repeatedly feel pain. They don't feel like they're getting better, and that's part of the coaching aspect. And so maybe new technologies will help us do supervised exercise at home. The other is revascularization, which is not emphasized in the guidelines because for claudication, it's really for symptoms. It's not a class 1 indication, but I'll say it really does work. These are data from Voyager. On the left, the ankle brachial index. In the middle, the WIQ, a PRO for walking function and PAD. And on the right, the Rutherford scale, physician-assessed scale. And all of these show dramatic improvements when you revascularize for claudication. And so there's a lot of it happening, and you can understand why people want to feel better and they are functionally impaired. So this was the sort of sum total of randomized trials that drove guidelines, and largely the 2005 and 2016 iterations. And they were all really therapies focused for MACE. At the top, you can see the ATT, which was the data for aspirin, a meta-analysis showing it reduced MACE by about 20%, 23%, increased bleeding, but there was no limb outcome benefit. Capri showed that clopidogrel was a little better than aspirin, maybe more so for patients with PAD, no limb outcome benefit, but it was actually FDA approved as a monotherapy. HOPE showed that ACE inhibitors were good for MACE, and the HPS or heart protection study showed statins were good. And so that was PAD therapy for many years, aspirin, statin, ACE inhibitor, maybe use clopidogrel as an alternative to aspirin. Efforts for DAPT or warfarin did not show benefit, showed a lot of bleeding. In the middle, there were really no effective therapies for post-revascularization adjuncts for medical therapy, one agent for symptoms, which was cilostazol. Okay, so now I'm going to talk about some of the new data, and I think the first is really lipid lowering or cholesterol lowering. And while we know that that works for MACE, and there are now many options out there, we haven't had as good of a sense of what it does in the periphery or for the lower extremities. And a lot of people ask, well, why would cholesterol lowering reduce the risk of acute limb ischemia when that's really a clotting problem? In fact, Dr. Narula, when here, showed that there were clots below the knee in a lot of patients with CLTI, no athero, which is a clotting problem. Well, the truth is that likely, and we've learned from Dr. Fuster, that athero develops in the aortoiliacs, and there's a lot of non-calcified plaque here. And the theory is that there are interval sort of plaque ruptures, distal embolization, which lodges below the knee and progresses disease, if not acute limb ischemia, chronic limb-threatening ischemia, and that's what they showed in their article. We've also done some analyses from a core lab out of the Voyager trial showing that you can quantify the amount of non-calcified plaque, and it's an independent predictor of acute limb ischemia below the knee. And so validating Dr. Fuster's notion there. And so I think that lipid lowering is different in the coronaries and the periphery, but what we're doing is stabilizing plaque in the aortoiliacs and reducing distal embolization. So does it work in the clinic or in the trials, yes. So this is data for evolocumab. These are major adverse limb events in patients with PAD from the Fourier trial, and you can see that there was a reduction in major adverse limb events, pretty dramatic. And I'll say the hazard ratios, as you look across the trials, are greater than for MACE because there's just more plaque to modify, and you can see consistent findings across the components of the primary endpoint. So when you put it together for a patient with PAD, PCSK9 inhibition isn't just a MACE reduction, which was about a 15% reduction in the overall trial. It's MACE or major adverse limb events, and you can see for that population, because they're so high risk and there's so much plaque, that at about 2.5 years, the number needed to treat was 16. Now, there's some controversy about what drives this benefit, although we observed that there was a linear relationship with the achieved LDL. So lowest is best for MACE. It's also true for limb outcomes. And so getting patients with PAD to a very low LDL is important. It is probably going to evolve, I think, in the US guidelines. The European guidelines endorse lower cut points for LDL, and I support that. So, this was one trial. It was validated then in a second trial called Odyssey with alirocumab, and you can see on the right side of this slide, the polyvascular patients, again, the highest risk with the greatest benefit. But you can see that for limb outcomes, the exact same pattern of benefit as we saw for Fourier with a hazard ratio of 0.59. So these are very effective plaque stabilizing drugs for patients with PAD. And while they are a class 2 in the guidelines, I think that the majority of these patients are going to need combination therapy to reach their LDL targets. What about other drugs? Well, these are data for ezetimibe, a relatively weak LDL lowering therapy. These are data from the IMPROVE-IT trial. And again, we saw that there was a reduction in PAD-type events, worsening limb symptoms or critical limb ischemia. And you can see in the patients with PAD actually a notable absolute risk reduction. So it's not just PCSK9s, but whatever you can get the patient, and ezetimibe is relatively easy to get now to add to a statin. There are other lipid-modifying drugs. So Dr. Bott led this trial looking at icosapent ethyl and this analysis for patients with PAD. And you can see, again, higher risk and a greater benefit. So this is another lipid-modifying therapy to consider in patients with PAD. Our surgeons still at the University of Colorado have a tick box for PAD patients on a statin, and our median LDL in our health system is probably around 90 to 100 in patients with PAD. And I think the take home from this is that the majority of patients are going to need multiple therapies, and we really should be pushing below 55 milligrams per deciliter. And it really does matter in terms of not only MACE, but major adverse limb events. All right, well, what about diabetes? Dr. McGuire gave a beautiful talk there on all of the different therapies, so I won't belabor those. All of these large trials had PAD subgroups, many written up by Subodh Verma, a close colleague and friend, and here's one of his analyses at the top for SGLT2 inhibition in patients with PAD and diabetes, and then GLP-1s, and there are consistent benefits in all of the cohorts. So as you think about ASCVD, and the ADA guidelines actually don't call out PAD specifically, but we should be using drugs in this class for MACE reduction. But I think what's really exciting, and probably what's next in the sort of area of PAD, it's not in the guidelines yet, is limb outcomes. Now, GLP-1s not only reduce weight, MACE, other things, direct vascular effects, but they're potent, reduces of CRP and inflammation as well. And there was an analysis out of the LEADER trial in the upper left, which looked at amputations. And these aren't major amputations like, acute limb ischemia amputation. These are diabetic foot ulcer infected limb amputations. And there was a significant reduction there with liraglutide. This spring, the FLOW trial, so semaglutide in patients with chronic kidney disease was published, and one of the exploratory outcomes was major adverse limb events, and you can see a strong trend there. It wasn't a PAD trial, but I think there's a signal there. And on the right side of this slide, there is an ongoing trial which should report hopefully at ACC, looking at semaglutide and walking function and quality of life in patients with PAD. So it looks very much like STEP-HFpEF, but for the patients with PAD, and this is very early stage PAD. These are Fontan 2A patients, so they have mild claudication. And I think what's really striking is that the baseline function is terrible. They don't think they're that bad, but when you look at them, most of them can only walk about 100 meters, and normal would be about 600 meters. So they're severely impaired. And when you look at the quality of life in the bottom panel here, in the blue, almost all of them have at least a mild, but most moderate or severe impairment. So I think this is an important take-home, is that most patients who have functional impairment from PAD aren't going to walk in the office and tell you that. They might say, I'm getting old, I'm slowing down, I have arthritis. There's a million reasons why they're not walking well, but they're really not walking well. And unless you look for PAD, you're not going to find it. SGLT and 2 inhibitors have had sort of a mixed sort of response in PAD. They clearly have benefit for heart failure, kidney complications, and MACE, for all the things that Dr. McGuire said. One trial, Canvas, did show a pretty consistent amputation signal, about a twofold risk, highest in patients with PAD. This was not consistently replicated across any of the other trials, although there were some, different signals, higher or lower. I think that most of us don't feel there's any issue here. In fact, I would encourage you to use SGLT2s, as you should, in patients with PAD. I think for some, if you have a patient with critical limb-threatening ischemia in front of you with a wound, the SVS guidelines would say that's maybe not the best time to start the SGLT2 and to stabilize the limb and then start it. But don't deny patients with PAD these therapies, because they have important benefits. All right, so then the last part's antithrombotic therapy. So I told you about the aspirin being a class 1 monotherapy for MACE reduction. These are the data from Capri, which really drove clopidogrel for PAD, and that was based on this plot on the left, which showed a really big benefit in patients with PAD. This has never been replicated. I'm not sure that this is a true finding, and it's also, whenever you look at analysis of heterogeneity in a trial, if you're getting more benefit for someone, you're getting less for another group. And so if you see MIs kind of leaning the wrong way, and as we migrate to more P2Y12 monotherapy for coronary disease, and we have many trials showing that that's a good strategy, I think this is probably a play of chance. But regardless, the trial was positive, and clopidogrel monotherapy is a reasonable strategy. In terms of post-revascularization, we haven't had a lot of positive trials. This is on the left side, dual antiplatelet therapy in the CASPR trial, so DAPT in PAD, and on the right, warfarin. And neither of these strategies have worked in PAD, despite the frequent use of dual antiplatelet therapy after endovascular revasc. We don't have any prospective data to support it, and we have a lot of bleeding. Nonetheless, it is a 2A in the guidelines. But that doesn't mean DAPT doesn't work. And so I've worked with Dr. Bada on a number of these analyses with aspirin and ticagrelor. This was from the Pegasus trial. And if you have polyvascular disease and you have a patient with PAD, actually, continuing dual antiplatelet therapy with a lower dose of ticagrelor not only is efficacious for MACE, it's labeled for that, but there's a greater benefit in patients with PAD. This was the most positive and cost-effective subgroup in the trial, with the trend for mortality. But I think for PAD, what is also very important is those adverse limb events. And you can see both Pegasus and the Themis trial showed significant reductions in major adverse limb events. So while we'll talk about dual pathway inhibition, there is a role for DAPT if you have chronic coronary disease or PCI post-MI patients. If they're on aspirin and ticagrelor, that's not an unreasonable strategy, although it's not endorsed by the guidelines. For PAD, is for CAD. I think the big surprise in PAD was the Euclid trial, which after Plato, which showed that ticagrelor was better than clopidogrel, it's a more potent, less variable P2Y12 inhibitor, it seemed like a no-brainer it would work for PAD. There's certainly a lot of risk. Nonetheless, it was not superior to clopidogrel here, and there was a signal in those who had concomitant CAD. There was an interaction, but that's, I think, exploratory. The guidelines don't recommend ticagrelor, but I'd say these curves look pretty similar, and it's not a bad option if you're going to choose a monotherapy and they can't get clopidogrel. They could use ticagrelor, but that's not highly recommended in the guidelines. Nonetheless, it wasn't superior, and I think that really told us the story that inhibiting the platelet's not the answer for patients with PAD alone. And really, we've talked now in a series of trials, and I'll cover some of the data about dual pathway inhibition. And so aspirin blocks platelet activation on the left, as does as clopidogrel or ticagrelor. But we know thrombin's a particularly bad actor in lower extremity peripheral artery disease and acute limb events. And so this notion of combining the two, it's actually an old notion because we tried it with warfarin, but the bleeding was just too high. And now there are newer agents that are safer where we can use dual pathway inhibition. I will stress that the dosing is critical. There were two sort of programs that looked at arterial disease. There was the Appraise program with apixaban, and they just kind of went for it with the therapeutic doses of apixaban that were used for atrial fibrillation. And we all think it's a really safe drug. I mean, it is in the right population, but it's a reminder that you need to understand the dosing in a different disease state. And even for a safe drug on top of dual antiplatelet therapy in patients with ACS, there was no benefit on the left. And the trial was stopped early for intracranial hemorrhage risk on the right. And so apixaban, even at the 2.5 milligram dose, is just too much anticoagulant for patients with PAD. In contrast, this was the Atlas trial led by Jess Mega and Mike Gibson at TIMI, and they did a very large phase 2 trial, which gave sort of an unexpected answer that for 10A inhibition in PAD and CAD, that lower is better, both for efficacy and safety. And they arrived at a dose of 2.5 milligrams twice daily, about 25% of the total daily dose for atrial fibrillation. You can see in Atlas here, there were reductions in MACE, CV death, all-cause mortality, and even stent thrombosis on top of platelet inhibition. And so this sort of raised this notion of dual pathway inhibition using a very low dose of a 10A inhibitor for disease. Now, the first trial to report, although this wasn't by design, it's because it was halted early for overwhelming efficacy, that was the COMPASS trial. And you can see the primary results on the left side of this slide where there was a reduction in MACE and mortality, about a 70% increase in ISTH major bleeding, but a net benefit. And you can see benefit in the limbs as well here for male and major amputation, and then particularly robust benefit in patients with diabetes as well as major adverse limb events on the right. And so Voyager was the post-revascularization trial partnered to COMPASS, and it was different than COMPASS for two reasons. One, it allowed dual antiplatelet therapy, so about half the patients were on triple therapy. And it also elevated limb outcomes to the primary outcome. So it was a 5-point composite of irreversible harm events of the heart, limb, and brain. It was a very positive trial with an overall net benefit, and then was the first drug to be approved based on these data for the reduction of acute limb ischemia and amputation, opening a new pathway for development for drugs. And while there's more bleeding, there was a clear net benefit. You can see about a 6-to-1 benefit risk ratio on the left, even in a broad population. And there have been multiple subgroup analyses showing consistency even for fragile patients, elderly, and others that we tend to undertreat. People have really struggled with what to do after endo. We're really wed to DAPT, and this is the first 90 days of treatment. You can see there's a very early benefit. So while some have promoted a staged approach, use DAPT for the first 1 to 3 months, and then switch to dual pathway, you're clearly losing efficacy by delaying the start of rivaroxaban. And when you look at just the top two boxes here, when you look at male on DAPT or not on DAPT, the efficacy is the same. There's no effect modification. So doing DAPT alone really isn't enough, and you should do triple therapy for 30 days, and then we would suggest dropping the clopidogrel. What about CLI? You can see here there was benefit in critical limb ischemia. On the left, this is including all-cause mortality and bleeding net benefit. So we haven't had a drug show efficacy before for CLTI, and this is now an adjunct to revascularization. And this is unplanned limb revascularization, which was the driver of the benefit in BEST CLI, and you can see a treatment effect there as well. Okay, I do want to talk a little bit about BEST and BASIL. These are the two revascularization trials that recently came out. They're in the guidelines. They tell you different answers. These are strategy trials about your first approach to someone with CLTI. In BEST on the left, surgery was superior. Surgery with a good vein was superior to endo. On the right, BASIL, endo is superior to surgery. These were very different patient populations. The ones on the right really had below knee disease, where on the left it was sort of more proximal disease. And there are a variety of reasons why these look different, but the take home is the guidelines do recommend a team approach and assessment for suitable vein in somebody with CLTI. Okay, so the guidelines in a nutshell, I've covered most of the data. In the red, I've highlighted sort of the new things that have been added. So we have the first drug on the left for MACE in male. So the aspirin, rivaroxaban are class 1 in the guidelines. It's recommended people get at GLP-1s and SGLT2s or SGLT inhibitors, but they're not for PAD-related events. They're really for the other outcomes that Dr. McGuire talked about, and then intensive lipid lowering. Whether semaglutide shows benefit for function in PAD, we'll probably prioritize that over other agents in this population. This is the very complex diagram on antiplatelet and antithrombotic therapy. I already explained the data, but you can do aspirin, clopidogrel, or dual pathway. All are class 1. It's sort of difficult to know how to weigh those things then in the guidelines because some reduce MACE in male, and largely I think the differentiator is bleeding risk. And if somebody's a high bleeding risk, monotherapy is probably safer. Otherwise, you'd favor dual pathway. Two quick comments I want to make. The guidelines really are beautiful in the acknowledgement of the complexity of this population, both the contributors to health disparities, on the left, and all of the risk amplifiers on the right. So these patients don't have one problem, they have many problems, and so we have to think about the context of their disease and the contributors to health disparities in order to optimize outcomes. And I do think that multi-specialty care team is now more important than ever, in that we have multiple medical therapies, revascularization approaches, and these are really high-risk patients that we need to work as a team, and that I think is evolving at many institutions. This is a little bit of a busy slide, but we published this in Circulation, the take-home from the guidelines, and you can see at the bottom, you should stratify their limb symptoms. How functionally impaired are they? How high risk are they for critical limb-threatening ischemia across the bottom? You need to think about the risk amplifiers. Do they have polyvascular disease? Do they have diabetes, chronic kidney disease? And then the sort of different axes of risk that you can modify with lipid lowering, diabetes, antithrombotics, and blood pressure, with the foundation being lifestyle modification, exercise, diet, smoking cessation. Just two good comments on the future. I think overall antithrombotics are underutilized, and certainly aspirin, rivaroxaban are. They've about doubled since 2021 in use, but majority of patients aren't getting them. Bleeding's part of that. There is a new generation of blood thinners out there, the factor 11 inhibitors, and this might be an exciting option in patients with PAD. The other area that's very interesting is LPA. There's several outcomes trials. Horizons will be the first to report next year, and it has a PAD subgroup. This is Greg Schwartz's work showing that there's a greater benefit of PCSK9 inhibitors in patients with a high LPA. So if you check it now, and you should, you might favor a PCSK9 inhibitor, and this may be a novel therapy for patients with PAD. The other is fibrates, although many would say, is the story over for fibrates? Paul Ricker and his group published data from Prominent, which validated data from field that there's a reduction in diabetic foot ulcers. And so there may be specific microvascular benefit for this population. The last comment I want to make, there's a trial that Dr. Bott's leading looking at coronary imaging in asymptomatic patients and treatment, with the notion that we should stage and treat disease rather than waiting for people to become symptomatic. I've sort of struggled with the ankle brachial index as the screening tool for PAD, although it is cheap and underutilized. Many patients with a normal ABI actually have terrible disease, and this is disease that could potentially be modified. So should we be thinking about imaging plaque as well as ABI, which is a hemodynamic measure, in terms of earlier use of preventive medications? All right, so I'll summarize. Medical therapy for patients with PAD is really evolving quickly. There's a focus on limb outcomes. We have FDA approval pathways for modifying limb outcomes, and hopefully we'll have a new therapy for function in PAD. I think this will force future guidelines of how to prioritize drugs, whether they have PAD-specific effects or not. Focus on LDL. It really works. Get your patients' LDLs very low. Most are going to need combination therapy. Don't wait too long to titrate. You can lose a lot of patients that way. Measure LPA, and there should be new data coming. I think the role of inflammation as a risk driver is clear, but I don't really know of any effective therapies other than GLP-1s, which lower CRP. And after TCT, I'm not sure what to think about colchicine, and there's an ongoing study in this population. There are unmet needs, safer anticoagulates, drugs for calcification, drugs for microvascular disease. So I think there's a lot of exciting work that's ongoing. For patients with CLTI, the outcomes from both BEST and BASIL are terrible, no matter what conduit is used, and really unacceptable. Patients are so sick, I wonder whether earlier detection and prevention is really the answer rather than just novel therapies for CLTI. I do think the complexity in this disease mandates a team approach. And I guess the final thing I'll say is that drugs don't work unless we use them. And we need implementation across diabetes, cardiometabolic disease, and so on. But PAD is consistently the worst treated population when you look at large cohorts. And we really need implementation science in PAD. All right. Thank you.